All right, so welcome everybody to Nerve. Thanks for being here. Today we're really fortunate to be joined by Dr. Rick Nelson, who's joining us from Indiana University School of Medicine, where he's an associate professor of otolaryngology, head and neck surgery. Dr. Nelson completed his MD and PhD degrees at the University of Iowa Hospitals, where he remained on for his otolaryngology residency and then his fellowship before joining Indiana as faculty. Dr. Nelson's a surgeon scientist and a neurotologist who runs a laboratory that studies molecular mechanisms of cochlear hair cell degeneration and hearing loss. And in particular, he's studied the role of serine proteases in hair cell survival and degeneration. His work involves using stem cells derived from 3D inner ear organoids and CRISPR gene editing to study the cellular pathways of genetic deafness. Dr. Nelson's widely published and has received numerous accolades, including the ACS Triologic Clinical Scientist Development Award, the Trustee Teaching Award, the Inspirational Educator Award, among many others. And today, Dr. Nelson will be speaking to us about facial nerve disorders. I'm really excited to have you here. Thanks for taking the time to speak with us today. And without further ado, I'll turn it over to you.
Thanks, Josh. Thanks for the introduction. It's my pleasure to be here. Um, my disclosures to start out. So I'm a consultant for Stryker and Cochlear America. It really doesn't apply for this talk. The one that may make me biased is that I trained at the University of Iowa, and some of the facial nerve decompression data was out of Iowa from Bruce Gantz's study, which I'll talk about a little later. So I give this similar lecture to my residents and fellow, and sometimes it's good just to review what the facial nerve functions are before we get into pathology. And so there's four main functions. The most obvious is the motor function, and that's for muscles of facial expression. All of those we know, but sometimes we don't remember the posterior belia digastric and the stylohyaloid muscle and the stapedius muscle. We also don't always think of the facial nerve as being a sensory nerve, and the sensory portion is on the posterior ear canal and the concha. And I tell residents the best way to think about this is patients with Ramsay-Hunt. And this is where the zoster virus erupts along the sensory branch of the facial nerve, and you can see those in this image where there's vesicles and edema of the posterior ear canal and the concha. The same patient, or a similar patient with Ramsay-Hunt, also has eruption of the cervical branch of the facial nerve. The facial nerve also has autonomic function. The first of which is the GSPN nerve, which, as you can see, Josh, can you see my cursor? Or should I use the?
I see the slide well, but not the cursor. I'm trying to make
pointer.
Oh, now I see your cursor. Now I can see it.
Okay, so this is the IAC labyrinthine segment, the geniculate ganglion, the tympanic segment, second genu, and the vertical mastoid segment. So the GSPN comes off of the geniculate area, and as you can see in an intraoperative picture, this is where we're doing a middle fossa CSF leak repair with encephalocele. You can see the GSPN nerve running from posterior to anterior along the skull base. And this carries preganglionic parasympathetic fibers to the pterygopalatine ganglion, which ultimately lands on the lacrimal gland and provides secretory function to the eye and to the nasal mucosa. There's also the chordotympany nerve, which comes off of the mastoid segment, as you can see in this diagram here. That forms some of the boundaries of our facial recess. So the chordotympany comes off and it goes lateral to the lenticular process of the incus and medial to the handle of the malleus. And that also carries preganglionic parasympathetic fibers to the submandibular ganglion, and then ultimately the sublingual and submandibular gland. Also, the other last function is special sense. So this is taste, the entry 2/3 of the tongue. And this, in addition to the sensory fibers, which I just described, travel on the nervus intermedius. So this is an intraoperative picture from a translabyrinthine approach where you can see the stump of the 8th nerve after we've removed the tumor. And you can see the facial nerve, and these are the motor fibers, and then the nervus intermedius runs between the 8th nerve and the facial nerve. So this portion right here is the nervus intermedius. Ultimately, in the middle ear and mastoid, as I talked about, is the cordotympany nerve, and that joins the lingual branch of V3 and ultimately innervates the anterior 2/3 of the tongue for taste. So the one thing we also may not always remember is what actually happens in the geniculate. The geniculate ganglion is a bunch of cell bodies, but it is not the motor function of the facial nerve. So the motor nuclei are actually in the brainstem of the pons, but the geniculate ganglion cell bodies are pseudounipolar neurons that contain the sensory fibers and also the special sense fibers. So that's what's made up of those cell bodies. So let's move on to acute facial paralysis. And I think one of the most important things with facial paralysis is doing a thorough history and physical and really understanding what the onset and duration of the facial paralysis is. Is it a complete paralysis? Did it happen within 3 days? Is it a progressive paralysis where you might be concerned about a tumor? Other symptoms that are associated, like other cranial neuropathies. Does the patient have other potential risk factors such as diabetes, or do they have systemic disease like sarcoid? And then laboratory studies, often you get an audiogram, and then we'll talk about how we test the facial nerve with a facial nerve conduction study or an ENOG, electroneuronography, and how we use that to determine prognosis and potential treatment. Radiographic imaging is really, I'll show you the guidelines, but is not necessarily indicated for somebody with a Bell's palsy. But you would get that if patients do not have return of function in 3 to 6 months after the onset, or they have this gradual onset where you may suspect a tumor, or they have some recurrent episodes of facial weakness. So most of us use the House-Brackman grading scale. There's many grading scales. Obviously, none of them are perfect. But what this scale is the 6-point scale, and most of us know this by normal being 1, total paralysis being 6. And at a grade 3, we often say they have full eye closure. What's interesting about a grade 4 is that they have no forehead movement. And so, and they also do not have full eye closure. Obviously, this is fraught with differences of opinion based on maybe your neurosurgical colleagues or yourself, or the tone of the patient, how old they are. But this is the grading scale that most people use currently. So the differential is very broad for acute facial paralysis. A lot of data suggests that Bell's palsy, which is the one we'll talk about most initially, is caused by the herpes simplex virus. There's also traumatic causes, whether that be temporal bone fracture or projectiles, or even during birth. Ramsay Hunt, we talked about initially, that's caused by the herpes zoster virus. Malignant otitis externa is another one. It's also known as skull-base osteomyelitis. This is a picture of a patient we had with the soft tissue on the CT and all of this inflammation on the MRI around the mastoid tip. And so there's some data suggest that decompression of the facial nerve in these patients may improve their outcome. I particularly myself don't do that, but some data out there suggests that facial nerve decompression may be beneficial. There's also acute otitis media. Typically, that's a pediatric or an adult patient with fluid within the ear, but no obvious bony destruction or intracranial complications and facial paralysis. I would recommend they be treated with steroids and likely myringotomy with or without an ear tube plus antibiotics. If there's cholesteatoma in the ear, that complicates things. Sometimes you would want to also treat them with steroids, but also potentially do a mastoidectomy to start to decompress the cholesteatoma, but may not do the full operation because of all the inflammation. Additionally, neoplasms, which we'll talk about a little bit as far as facial nerve neoplasms, can cause weakness. Intratemporal lesions, such as this one shown here on the MRI and also CT, which is a jugular foramen paraganglioma. You can see here the erosive changes to the bone, and it's right close to the descending segment of the facial nerve. So patients could present with facial weakness, or they could have progressive weakness as the tumor gets larger. There's also Melkerson-Rosenthal syndrome. This is characterized by the triad of recurrent facial paralysis, oral facial edema, and then this fissured tongue, which is shown here in this image, also known as lingula plicata. Osteopetrosis is where there's excessive bone growth of the skull or skull base surrounding the skull base, the facial nerve foramen. Guillain-Barré is an autoimmune disorder, often causes cranial neuropathies or nerve disorders. If you live on the East Coast, particularly Maryland, Virginia, you may see more tick-borne diseases such as Lyme disease. So we remember the Borrelia burgdorferi, and then the skin lesion that we see from the tick is the erythema migrans. And then this paper that they, 2022, they talked about facial paralysis, and in fact, 30% of the patients they confirmed by serology or CSF had bilateral facial paralysis. Good news is the outcome is usually excellent as long as people are treated with steroids, often with antibiotics to treat bacteria. MS or sarcoid or other causes. So oftentimes if you have a long-term facial paralysis patient and the let's say you're looking for a tumor, everything else is negative and the PET scan's negative, sarcoid may be something to consider as a granulomatous disorder and may need a facial nerve biopsy. So let's move on to Bell's palsy. This is the encompasses 80% of all peripheral facial nerve paralysis. As I mentioned, it's a diagnosis of exclusion. And I also mentioned that it's usually due to the herpes virus. This was back from the 90s when people have used PCR to identify the viral DNA around the nerve. And also using mouse models where they inoculate the mice with HSV, they get facial paralysis. So most people, I think, feel that this is most likely the cause. So the important aspect of Bell's palsy is that when there's inflammation and swelling of the nerve, there's constriction of the nerve, which causes the decreased conduction of the nerve. And the most likely area of constriction is the labyrinthine segment, which is shown by the arrow on the CT. This is a normal caliber labyrinthine segment. And so when there's edema and swelling, that's where you get the constriction point. So on this scan, this is a patient who has active Bell's palsy. You can see the enhancement of the proximal tympanic, geniculate, and the lateral IAC component, canalicular component of the facial nerve. And this histology diagram basically demonstrates that the fallopian canal is the narrowest portion of the canal, and it's only 0.68 millimeters in diameter. So any swelling of the nerve can cause it to be constricted and stop functioning. And also, this would be the area that we would want to target if we were going to decompress the bony canal of the facial nerve. So what happens to Bell's palsy patients if we don't treat them? This was back from 1982, and the natural history suggests that most people actually get better without treatment. However, there's a significant percentage of patients, 16%, that had diminished or poor outcome, meaning, let's say, a House-Brackman 3 or 4. And obviously, we all know that we treat them with steroids now, with or without antivirals. And this was a meta-analysis published in the journal JAMA, which looked at randomized controlled trials or cohort-involved trials with steroids without antivirals or steroids with antivirals, showing that the benefit of the corticosteroids is pretty much been shown in multiple trials to decrease the potential for a bad outcome and improve the rates of good outcome. So these are the current guidelines that were published in 2013 for Bell's palsy by the American Academy of Otolaryngology. So we can go through these, but I recommend that you look at this document. It's freely available online. But they strongly recommend that you do a thorough history and physical to make sure it's an acute onset facial paralysis. They recommend strongly against laboratory testing or diagnostic testing if everything else is otherwise consistent with Bell's. They obviously recommend treating with steroids. In my clinical practice, I do treat with steroids and antivirals. I think the risk or the side effects of antivirals are minimal. Obviously, we want to take care of the eye if the patient cannot tear and cannot close the eye, so that's also an important aspect. And then they really said that it's optional if you want to use electrodiagnostic testing in patients with complete paralysis. And then they went on to say that surgical decompression, and I'll show you some of the data, they really can't make a recommendation for or against surgical decompression. And that goes similar to physical therapy or acupuncture. And then they also recommend that patients have close follow-up to make sure that there is recovery of the facial nerve. So most of us know this, but taking care of the eye is very important, particularly if they cannot close the eye, taping it at night or patching it, getting ophthalmology involved if there's persistent pain or vision changes. And this is the dosing typically used for prednisone or valcyclovir. And then we use facial nerve conduction studies for complete paralysis. So if anybody has incomplete paralysis or just paresis, we don't need to get facial nerve conduction studies. So a couple important concepts. All Bell's palsy patients, their functional facial function improves from where it was the worst. However, not everybody gets back to normal. If they don't improve, then you need to get imaging to rule out some neoplastic process. And regardless of medical management, there's a small percentage of patients that have poor recovery, meaning they have House-Brackman 3 or a 4. So the real question is how do we diagnose that, and how do we determine which patients are at risk of having a poor outcome? Well, for electrodiagnostic testing, as I mentioned, we only get that on patients with complete paralysis. So when you examine them, if you see any flicker of movement, they don't need to have electrodiagnostic testing. And really the function of the test is to determine the quality and the degree of axonal degeneration. The advantages are that you can do maximal stimulation and you have a recording strategy of the peripheral nerve, and you can differentiate neuropraxia from the actual degeneration of the nerve. The disadvantage is that you can't really differentiate between axonopnesis or neuropnesis, which means that the nerve is intact or is not intact. So if it's completely degenerated, it would still show the same as if the nerve was completely transected, for example. And it really only has the value within the acute phase within the first couple of weeks. So this is a schematic of the method of doing a facial nerve conduction study. So we have our neurologist do this. I think you need to have somebody who does this on a regular basis. The idea being that if the nerve is injured, the distal portion from the injury will degenerate to the muscle. So what we're doing is we're measuring the conduction through the portion of the nerve that we've hypothesized has degenerated. So we stimulate the stylomastoid foramen, and then we record distally at the muscles around the mouth or around the eye. And we get a compound action potential. And we do both sides, the normal side and the abnormal side. So this is an example tracing of an uninvolved side and an involved side. And what basically you do is measure the millivolts of the response from basically the P1 to the N2. And so when you get the data back, you basically do a simple division equation. So for example, if the involved side is only 0.3 millivolts and the uninvolved side is 1.8, you would do the division minus 1 minus the divided product times 100, and that'd be 83% degenerated. So that's how you calculate the percent degeneration of the nerve. It's also important to get EMG, which we'll talk about in just a second. So this is a nice graph which demonstrates that what we're seeing on our ENOG correlates with what we see on pathology. So the higher the degeneration percentile that we see on ENOG correlates with a high percentage on histopathology. So I think this graph shows a pretty strong correlation, which means that our test potentially has high accuracy for predicting degeneration. EMG, basically, you record from the neuromuscular junction with needle electrodes, and you're asking the patient to forcefully contract the facial nerve. And you're really trying to do a voluntary motor unit potential detection. And so we do this when patients have 90% degeneration or more. And what's interesting is that you could have greater than 90% degeneration on ENOG and still have active motor units. So the people that qualify for the worst outcome are those with 90% degeneration and no active motor units on EMG. So if they have active motor units and they're 90% degenerated, just continue to treat them with steroids and they don't qualify for surgery. So I'd like to talk about the data. Although it's controversial, I just want to go over what the data says so that everyone knows and can talk about it regarding facial nerve decompression. And I think this is the landmark study in 1999 by Gantz. There was a multi-center study from Iowa, Michigan, and Baylor, where they identified patients with facial paralysis over many years. And they included patients that met that criteria of 90% degeneration and no voluntary motor units on EMG. And then what they did was they basically allowed them to make their own decision whether they wanted to have surgery or just treat themselves with steroids. Everybody got steroids regardless, but some elected to have the decompression and some elected to just have steroids. And then they compared the two groups. So first, it's important to know if patients have less than 90% degeneration, this is what the outcomes are, which means that essentially everybody gets a really good outcome, Haas-Brackman 1 or 2, if they don't meet that criteria. So it's also a good prognostic thing that we could use for our ENOG to say you have a good prognosis because you did not meet the criteria for surgical decompression. So the decompression results, again, those were patients that met the ENOG criteria and no voluntary motor units on EMG. And so when they did steroids alone, you can see that 42% of the patients achieved a good outcome. Compared to those with decompression, 91% of the patients achieved a good outcome. So this is basically the data from that study. And what sort of I tell patients is that the decompression, your chance of having a recovery that's normal or near normal is 91% with a decompression, and it's less than 50% with steroids alone. Again, this is the best data that we have, and it should be done by somebody who's highly skilled at facial nerve decompression of the labyrinthine segment. There are obviously risks of the surgery, but in skilled hands, this is what the data suggests. And I think that's probably why they don't specifically say that it's recommended. They just really can't make a statement about whether to recommend or not the decompression. The timing is also important. So they looked at their patients and when they decompressed them. And you can see this, when patients were decompressed within 14 days of the onset, they typically achieved a grade 1 or 2 outcome. If they waited longer, they rarely got to a grade 1, and many of them were still grade 3s. So timing is also important for the facial nerve decompression. So this is the general recommended algorithm. So paresis is on the left. So if they have incomplete paralysis, you're going to treat them with steroids with or without antivirals, and you're going to follow them every few days. If they still are incomplete paralysis, then you follow them up as an outpatient. If they progress to complete paralysis, then you put them into the ENOG protocol. If they've passed the 14-day window, then you follow up several months later because they're outside the treatment window. If they have complete paralysis, but it's only within the first day or two, we have to wait for Werner degeneration to set in to be able to do the testing. So we treat them with steroids, bring them back at 3 days, and test them with the enog. If they're within 3 to 14 days, we test them with the enog, see if they have 90% degeneration, and also with the voluntary motor units on EMG. And so if they have no voluntary motor units, then we could recommend decompression to those patients. So in this scenario, if a patient's day 7, but they're only 70% degenerated, we may bring them back at day 10 and retest them to see if it's gotten worse to where they qualify at that point, or if it's stable or even better, then we can move them to the observation camp. Or if they become outside the 14-day window, then we move them to observation. So I'd like to show you a video of a facial nerve decompression through middle fossa approach. And this was done by myself and Dr. Gantz back when we were at Iowa. So we made a middle fossa craniotomy. We make it about 4.5 by 4.5 centimeters, centered at the root of the zygoma. And so to give you some orientation, this is the right ear. So to the right is posterior, to the left is anterior. So we're elevating from posterior to anterior to make sure we don't avulse the GSPN nerve. We place the house urban retractor down at the Petras ridge. And as you can see first, you'll see that we're identifying the superior semicircular canal to blue line that. And you'll notice that we've already identified the tympanic segment, the geniculate, lateral to the burr, and now we're drilling the IAC. And so the blood's covering up, now it's better. So here you can see just to the left of the burr head up on the bone is where the geniculate is. And we've uncovered the epitympanum. So you can see the head of the malleus, it's kind of blurry up at the top. Head of the malleus, the incus, and the tympanic segment. And using this 2-diamond burr, we're drilling out the labyrinthine segment. So as you remember from the anatomy, as long as you stay on the top of the facial nerve, you should not get into the cochlea. The cochlea is very close to the labyrinthine segment. And so take your time and follow your anatomy from the geniculate to the IAC. So we're removing some of the bone. You can see the entire course there, the labyrinthine segment. Sometimes we're better at flicking off this bone than others. So that's the geniculate getting into the proximal tympanic. So we decompress that whole segment. The proximal tympanic is also important to identify and decompress. So now it's a better view of the tympanic segment. Again, lateral to the burr is the malleus head and the incus. And then we can use this right angle to remove some of that bone. Fast forward here. So then we can use our stimulator. And sometimes if you turn up the stimulator, you can actually get it to stimulate the tympanic segment, but you will not often see it stimulate proximal to the labyrinthine segment. And then we also cut this arachnoid band that's lateral to the at the lateral aspect of the IAC at the fallopian canal. And then we also make a small incision in the perineurium to allow the nerve to swell. And then that's the final decompression. You can see the tympanic, geniculate, and the labyrinthine segment. So let's move on to some cases that aren't Bell's palsy. So this was a patient that came to me, and she's 40 years old. She had profound hearing loss. It's been progressive since childhood. Her facial nerve function is totally normal. She had this remote history of a stapes many years ago, which she just said didn't really work. And this is her audiogram, which shows bilateral profound sensorineural hearing loss. So given her history of this middle ear surgery. I was lucky enough to get a CT scan on her, because often I just get MRIs for my adults. What you can see on the right ear is that her facial nerve is aberrant. So you can see here, here's the IAC, the cochlea, the proximal tympanic. Here's the stapes. And you can see as we go down, the facial nerve is going right over the promontory, inferior to the stapes, and right over the oval window. It's going right over the oval window. And then the jugular bulb is quite high. I also think that her sigmoid's kind of strange. It's got some diverticulum. So I wonder if there's some spectrum of developmental defect within her temporal bone. Sometimes we see that with charge syndrome, but she didn't have any other features of charge. So this was the intraoperative view, knowing that anatomy. And then we were placing the sequential cochlear implant in her right ear. We did her left ear first. This is the anatomy. So you can see the facial nerve is inferior to the stapes, which is completely abnormal. It's covering up the round window. And then the jugular bulb is up to the level of the cochlea. So this was where we were going to make the cochleostomy. So this is the video. So just identifying sort of where the anatomy is here. So facial nerve to the left of the burr. And the jugular bulb, obviously, we're trying to avoid. So we're just slowly making this cochleostomy around the facial nerve. So we found the basal turn, and then we'll place our implant. And so I guess the fortunate thing is we had the CT to know this preoperatively. But if you're drilling the facial recess and things seem abnormal, I would recommend that you identify the nerve inferior to the facial recess. As you can see, it's more in a normal position inferiorly than it is in the middle ear space. So case number 2. So this is a 60-year-old female with muffled right-sided hearing. She did have a remote history of a Bell's palsy episode that completely recovered 4 years ago. She does have some notable facial twitching, but her facial nerve function otherwise is normal. She has this mixed conductive hearing loss on the right side with 96% discrimination. And this is her MRI, which shows this enhancing lesion in the proximal tympanic segment, both on the axial and then also on the coronal to the right. And then the CT shows it abutting the head of the malleus and the incus, and that soft tissue lesion. So it's right within the facial nerve, and so this appears to be a facial nerve schwannoma. The CT does not show any calcifications within the lesion, so it's unlikely to be a facial nerve hemangioma. So I think this is a really nice paper from the House group in 2011, which proposed a facial nerve schwannoma management algorithm. So if the tumor is stable in size without bony confines or there's stable facial nerve function, and what they mean by that is House-Brackman 3 or better, then it's recommended that you observe. If the bony confines of the tumor, if it's within the bony confines and it's increasing in size, or there's worsening facial function, you should consider bony decompression. Or if there's like recurrent episodes of Bell's palsy. In an enlarging tumor without bony confines in the CP angle or middle fossa with normal facial nerve function or good facial nerve function, then consider radiation. And then if it's a big tumor and the facial nerve function is 4 or worse, or there's compressive symptoms or there's a failure of radiation, then consider resecting and grafting. So I think the idea being that it's a movement towards conservatism with the schwannomas. Because if we cut out the nerve and graft it and the facial nerve is normal, the best we're going to get is a 3 with no forehead movement. So this patient actually had a scan a long time ago which demonstrated to be stable over about 10 years. So we've been continuing to watch her, and her facial nerve function has been very stable. So we're going to continue to observe. So this is case 3. So this is a 71-year-old male. He had 3 months of dizziness and muffled hearing on the right. Then 3 days before he came to see me, he had some facial twitching, although his facial nerve function is still House-Brackman 1. He has this high frequency sensory neural loss, but does have decreased discrimination in the right ear of 76%. What you can see on the MRI is there's enhancement within the lateral IAC, the geniculate area, and also on the coronal, you can see that at the geniculate area. So this looks like a facial nerve schwannoma, more in the IAC or geniculate proximity. However, the facial nerve function is still normal, and the hearing is still okay. But to confirm that, we went on to get a CT scan. And so when you think about a facial nerve schwannoma in this area, it often dilates or widens that labyrinthine segment. So you can see at the red arrow, comparing the right to the left side, how widened that labyrinthine segment is from the tumor. And what's very concerning, obviously, on the coronal is that this tumor is starting to erode into the cochlea. So that's probably why he's starting to have some mixed conductive hearing loss or decreased discrimination. So we elected to observe, and this tumor grew pretty rapidly in 6 months. You can see on the bottom row the increase in size of the tumor. Also, his hearing deteriorated some with 64% discrimination. So following the algorithm, facial nerve function is still normal, a growing tumor. We decided to do radiation. So we did gamma knife stereotactic radiosurgery. And so the good news is the tumor is stable and his facial nerve function is stable. The unfortunate news is that his hearing has deteriorated to profound deafness. So I'm not sure how we could have prevented that given the CT findings initially, but the facial nerve function and management, I think, was reasonable. So this should also be differentiated, as I mentioned, from facial nerve hemangiomas. These often are smaller tumors. They often have this on the axial CT on the right. You can see this sort of bony stippling within the tumor. It's usually in this perigeniculate area. And these patients often have worse facial function for the size of the tumor. So they'll often have progressive facial weakness, twitching, or synkinesis from recurrent paralysis episodes. So just something to recognize in the imaging features that differentiate hemangioma from a schwannoma. So let's move on to traumatic facial paralysis. We'll talk briefly about temporal bone fractures, and then there's also penetrating trauma. What I think is important to think about for a newborn, which doesn't come up very often, is how do we differentiate a newborn that has facial paralysis, whether it's congenital or whether it's a trauma from delivery? For example, is it congenital from, like Mobius syndrome or a congenital absence of the facial nerve within the during development? In fact, you would want to do the ENOG early. You'd want to do it within 2 days because you could differentiate between a nerve that's otherwise normal and has not undergone degeneration from a trauma, or compared to one that would be no response at all, which would be a congenital defect. So you'd want to do the ENOG within 2 days prior to well-earning degeneration. So this is kind of opposite of what we do with acute facial paralysis. So temporal bone fractures briefly, we worry a lot about this. We see a lot of traumas. Is it partial or complete? I think is an important thing. Your CT will really drive your decision making. You really want to know, is the nerve intact or is it not? I think if it's intact and they have complete paralysis, we just follow the algorithm that we do for Bell's palsy. And the one caveat is that many temporal bone traumas, if they have a high velocity injury, they often have intracranial trauma that often complicates our ability to manage the facial nerve in an expedited fashion. So they often have contusions of the temporal lobe, so you wouldn't want to do a middle fossa on that. They may be intubated, they may have polytrauma, so oftentimes these get quite complicated. But I think to summarize it, you really want to say, is it complete? Is the nerve intact? And if it is, then follow the Bell's algorithm. If it's transected, then obviously at some point you want to put that nerve back together. So this is case 4. So this was kind of it's a pretty interesting case that it was a young male who had a gunshot wound to the temporal bone. You can see the bullet fragments there on the CT scan. He was initially at an outside facility and he had total facial paralysis along with complete hearing loss. And so he was seen by another ENT group and neurosurgery. And you can see on this CAT scan, there's a large loss of the tegmen. And there's bullet fragments within the temporal lobe. So those small bullet fragments, the neurosurgeons weren't planning to intervene. And the ENTs, for whatever reason, decided they wanted the patient to come back in a couple of weeks, even though the patient had complete facial paralysis. Suffice to say, the patient came back to the emergency room with signs of meningitis, with photophobia, chills, and he had pretty persistent right ear drainage that was both purulent and clear fluid. So you can see on this CAT scan, he has a temporal lobe abscess with some pneumocephalus and vasogenic edema. Still has the facial paralysis, and he still has the deafness on the right side. So now we have a gentleman who's got a foreign body in his ear, facial paralysis. He's got an infection of his temporal lobe and his ear, and he likely has a CSF leak. So, and it looks like on the CAT scan, as much as you could tell, that the facial nerve was transected, and he's about 13 days out. So how are we going to manage the facial nerve in this situation when there's an active infection and an ongoing CSF leak? I didn't really think that we should be doing a nerve graft or an anastomosis of the nerve while it's actively infected. So my plan was to drain the temporal lobe abscess with neurosurgery, stealth guided, and then perform a petrecectomy to control the CSF leak. Treat them with antibiotics to resolve the infection, and then come back 6 weeks later and do the facial nerve neurography. And so I'll show you the video of this one. So this is stage 1. So you can see it's already 13 days out. There's granulation in the mastoid. We elevate the canal skin down to the middle ear, remove the ear canal, and that's the bone, the bullet fragment in the middle ear space. Up against the tegmen. So we close off the ear. You can see this little flap knife, we don't have any tympanic segment of the facial nerve. It's completely gone. So plug the eustachian tube, and you can see to the left, we have this tegmen defect, temporal lobe. And so we put Duragen up there and then swing temporalis muscle down. So this was stage 1. And then the stage 2, we came back, and since he is deaf, we did a translab approach. We decompressed the facial nerve from the second genu to the stylomastoid foramen. And then we opened the IAC and took it from the labyrinthine segment down to the brainstem and reflected it onto the posterior fossa dura. And it's actually got enough length to do a primary neurography. So this little gel film, and we can get the ends to attach to each other. So we place 1 or 2 9-0 neurons, reapproximate the ends. And then we place Tisseel over the nerve. And then we reconstruct the area, the CSF leak, with an abdominal fat graft. So a year later, patient was symmetric at rest. He had some full eye closure, mass movement, and no forehead movement. So for a grafted nerve, that's kind of as good as you can get. So, so I think that was a good outcome to treat that situation. I'd obviously be happy to hear if anybody had any other thoughts on how to treat that case, that complicated case. But suffice to say, I want to thank you for having me today. This is my email. Happy to take emails or questions. This is the landscape of Indianapolis on 4th of July.
Awesome. Thank you so much, Dr. Nelson. That was a great talk. And I have a couple of questions, and we'll make sure that we'll have a hard stop a little bit before 6, so that you have so they'll end on time. The first thing that I was wondering about is um, in the situation where you're a neurotologist and you either don't have ENOG and EMG, or you don't have someone who does that regularly. Maybe you have a neurologist that's done it a couple of times, doesn't really feel that confident in it. Um, are there any, if that's the situation, would you say, okay, if for the Bell's palsy specifically situation, well, unless you really have everything you need to do this and track it over time with repeated ENOG and the EMG, you really shouldn't be messing with decompression at all? Or would you imagine like an alternative sort of rough way of estimating things if you didn't have the setup to perfectly do it in the way that it was outlined in the paper, and that it is at certain centers? Because I'm thinking about for myself, for instance, even if I'm even if I see somebody who has a complete facial, fairly confident they might benefit, but really maybe you could get one EMG, or maybe the neurologist isn't available for a few extra days, timing gets changed. How rigorous would you be at sticking to that protocol? And if you can't do it really exactly that way, should you, in your opinion, should you just kind of avoid surgically intervening for those patients?
Yeah, so I would say that when I first started, it took some, I was kind of told, well, we don't do that here. And so I sort of met with the neurologist and described what I was interested in doing. And I think it just takes the effort to work with neurologists. Usually they do a lot of electrodiagnostic testing for their patients, the movement disorder people, those sort of things. So, um, they'll do carpal tunnel stuff. And so they probably have the equipment. It's really discussing with them, are they interested in helping? Um, would they be available? That's the thing, is like, are they going to be available like within 24 hours or 48 hours to help you? Um, but to answer your question, I would say not only you obviously don't want to operate on somebody without the information. Secondly, if you don't do those operations on a relatively frequent basis, like you feel comfortable doing a middle fossa facial nerve decompression, it's probably one of the most challenging things that we do as neurologists, because of the fractions of a millimeter between the cochlea and the vestibular nerve and all this sort of stuff, that maybe the patient's best served by not having a surgery.
Thank you. Yeah, that makes a lot of sense. I was
Hey, Josh,
curious.
real quick.
Yeah.
Hey, one thing I was gonna. Hey, Rick, thanks so much. Awesome talk. One thing I agree with Rick. Talking to your neurologist is really important, because they also have they have different names for a lot of these very similar tests. So like what they call it within their field can be very different than what we call it, but it's actually the same thing, and you get the same results. So I mean, most major medical centers have the capacity to do this, but yeah, as Rick said, it's a whether there's that partnership there or not. But
Yeah, and they call it, they don't call it ENOG here. That's a good point, Teddy, is that they call it facial nerve conduction study. So that's actually the order in the chart, is facial nerve conduction study.
I was also curious in the rare circumstances of where you have the facial nerve tumors, and you shared some cases with that, for the indication where you might be doing decompression as opposed to radiation, resection, or observation. Would you then focus your decompression on the area of where you see on the imaging the tumor to be widening, or would you be decompressing more widely as much as you can? I mean, obviously, it depends on the hearing status whether or not you would consider doing like translabyrinthine decompression of the whole nerve, or whether you would just be still focusing on the labyrinthine segment through the middle fossa. Like, how would you approach targeting your bony decompression in the circumstance where you would be doing that for a facial nerve tumor?
Yeah, so the so some tumors are like in the mastoid, so they might be in the mastoid segment, they might be in the tympanic segment. So optimally, you would decompress the area before and after the tumor, those bony areas, targeting the tumor itself. Not saying, well, the tumor's in the mastoid, but I'm going to decompress the labyrinthine segment. That's not going to probably help the patient because the pathology is really where the tumor is located. So I think I would, yeah, you just want to focus where the tumor is located.
And for the last, like, really, really awesome, interesting case you shared with the bullet fragments and the temporal lobe abscess. In the first stage, I was thinking about like where you're draining the temporal, or I assume neurosurgery draining the temporal lobe abscess, and then you're fixing the leak, and you kind of rotated the muscle down. I was wondering, like, were you concerned that in sort of fixing the leak in that acute setting where there's also an intracranial abscess, that you might be sort of like trapping the egress point of the infection? Like, basically, like, kind of sometimes if we, for instance, have a CSF leak, meningitis, try to treat the meningitis and whatnot first and cool it off and then go back and fix the leak. Like, were you, or maybe that already was done in sequence, but were you concerned about sort of trapping infection in the process of closing off the ear and fixing the leak before going back and decompressing the nerve, or re-anastomosing the nerve?
Yeah, so I've done a lot of these temporal lobe abscesses with our neurosurgery colleagues, and so in fact, some of them, are okay with a centimeter or centimeter and a half abscess kind of hanging out there and not draining it. The best thing I think is when they use stereotactic guidance. So that same case, they just made a little burr hole above the ear and they use guidance to stick their drain in there. And really, you can estimate the volume of pus that's in there based on the size of the abscess, and they should be able to get out that volume of pus to make sure that it's decompressed. We've even done it where you can use sort of an ultrasound to determine if the abscess is decompressed. Because what you don't want to do, as you mentioned, is have a 3 centimeter abscess, take some pus out, and still have a 2 centimeter abscess that's walled off that still is going to potentially have the patient have issues down the road. So I think working with your colleagues to make sure it's drained appropriately to start. I wouldn't rely on it to drain into the mastoid cavity because I plugged the eustachian tube, and that's supposed to be kind of a sterile space. That's what I'm trying to create because there's no real egress for it out there either. So hopefully they do a good job of decompressing it for you.
Thanks very much. Got just a couple minutes left. I want to give anyone else a chance if they have a question. I think Dr. Meyer started to speak before and I interrupted him, but I also want to make sure we finish on time.
Have a practicality question. So, Rick, you spent 7 years training at Iowa, the mecca for the facial nerve decompression for Bell's. How many did you do?
You mean at Iowa or since I've gotten out of Iowa?
At Iowa.
I think we did 3 over my 2 years.
That's about what we did. How about since you've been out?
I have probably done 5, but a couple of those are traumas. So bony impingements as opposed to true Bells.
Yeah, that's probably similar to me in 20 years. So patients wanting surgery, getting patients in quick enough is a big problem, and then testing.
Yes.
Some of Bruce's data shows that maybe 10 days is better than 14 days. So maybe if you're even outside that 10-day window, might be a challenge. Those cases were good. We've seen actually some similar ones during Josh's tenure here, and helpful. I had one last question. Was your cochleostomy site anterior to the round window? And then the related question would be, if posterior had been taken down further, could you have possibly entered through the round window and given yourself some more length on the implant?
Yes, it was anterior to the round window because it was covered by the nerve. And I guess I could have done something like gone under the facial, is what you're saying, posteriorly.
Yeah, if the nerve's not in the way, then perhaps able to get underneath it. Just the anatomy on those is very challenging, and even ear by ear differences on a kid with bilateral problems is going to present different challenges. So your way looked awesome, and looks like you got a nice insertion, and hopefully the patient's doing well.
Yeah, and in fact, I looked at the outcome. So the other ear obviously was normal anatomy. I think the sentence score on that normal ear is 83%, and the ear that I did with the facial nerve problem was about 65%. So may not be as good, but I still think it's a pretty good outcome.
And one question about that larger growing radiated nerve up at the geniculate with the ear now deaf. Would that patient's insurance allow for cochlear implantation?
We could. The one thing I thought about with that is facial nerve stimulation, given it's eroded into the cochlea to some degree. But yeah, you could consider that. We've gotten more and more coverage for single-sided.
You were anticipating the next question. That's awesome.
All right. Well, it's just about 6 o'clock. Thank you so much for spending the time with us and for your excellent talk, Dr. Nelson. I'll get this uploaded in the next day or two, so those who couldn't sign in can reference it as well. I'm sure there'll be a lot of interest in this one. So thanks again. Really appreciate you being here and doing this.
Thanks for having me. Good to see you all.
Thank you very much, Rick. Great job.